Welcome back. Some long awaited reforms are changing the rules surrounding involuntary detention of people with mental health and substance abuse issues. To discuss the new law and the changing conversation around mental health and law enforcement, we're joined by Officer Chris Rousselle with JSO's Behavioral Crisis Response Unit. Welcome, Officer.
Thanks for having me.
Jacksonville Sheriff's Lieutenant Robert Lestrange Jr., who oversees the
Good
unit.
morning.
Good morning, Lieutenant.
Good morning.
And Dr. Christina Cauffield at LSF Health Systems, which coordinates behavioral health care for the state in 23 North Florida counties. Welcome back, Dr. Cauffield.
Thank you. My pleasure.
So I'm going to start with you, Doctor. These laws impact the so-called Baker Act and Marchman Act laws. Those are 50-year-old laws in the state. Remind us what they each do.
Well, they were originally brought forward in 1970 to ensure that individuals that needed help, that were at risk of harming themselves or others, would be able to be involuntarily admitted to a crisis stabilization unit. And as time has passed, we're finding that reform was necessary. Representative Maney out of the Panhandle really was the champion of this bill, and he took several years to push it through, but very grateful that it's come to fruition this past legislative session, and there's some really good things in this bill that were needed.
Why was reform needed?
Well, we're finding that children, particularly here in Florida, were some of the highest in the nation for receiving Baker Acts. And so people were very disturbed about this. Parents, loved ones felt like they were out of the loop. So there's some language in this bill that addresses that. There are lots of concern around just how many people are Baker Acted that really do need it. And is there another way to put them in a less restrictive environment?
These detentions are initiated by family or loved ones. Is that correct?
Family, loved ones, law enforcement, school personnel. So referrals come from a variety of sources.
And Lieutenant Lestrange, one change in this is it gives law enforcement some more discretion that it has not had in the past. And tell me if my reading of this is correct, but the former law basically mandated that if an officer was summoned to a Baker Act type circumstance, that somebody wanted to Baker Act a person, that they were required to basically take that person into custody. That person would then be held generally for 72 hours, 3 days.
Correct. What the new legislation helps us with is the officer's discretion. Instead of perhaps making it mandatory, as you said, for us to Baker Act someone, now we have a little more discretion. We consider what we would call voluntary examinations, or we can, especially as a unit, help people get services. And it gives us a lot more latitude to kind of just, especially our unit, to talk with people, figure out maybe that they might be having a bad day, but they don't necessarily need to be Baker Acted. Whereas in the past, officers were afraid that if citizens said certain things to them, they would automatically be Baker Acted. So now we have a chance to really kind of help people with services they might need, whether that be through MHRC, child guidance, any kind of service that might help them with their mental state at the time and in the future. So that's where it helps law enforcement. We're not required now. It gives us the authority to Baker Act somebody.
And as Dr. Cauffield alluded to, I would imagine that that's a very difficult process and decision to make when it's a child that's involved, if you're being called to a scene and feeling required by law to take that child into custody.
Whenever we're dealing with children, it's such a delicate situation, and getting a child the best help, the best care, and not perhaps putting them in the back of a police car and giving them that experience certainly could be traumatic for them. So opening kind of the laws, opening to giving parents and children a different direction when it comes to children who might be experiencing some kind of mental illness is certainly favorable for everybody.
Yeah. Officer Rousselle, you work with JSO's Behavioral Crisis Response Unit. Why did you want to join that unit? And tell us a little bit what your day-to-day job is like.
So the unit started back in 2019, and I was kind of one of the first officers to jump in on it. There was a leader that had an idea, and we kind of put our ideas together, and MHRC had presented this program to us.
That's the
And
Mental Health Resource Center?
yes, the Mental Health Resource Center had presented this program to us as a pilot program. So we jumped into it full speed just because we knew that there was a need to provide these services to the people in need in the community. And that's one of the main reasons why I jumped into it, was to try to avoid, individuals being Baker acted or arrested when they could use other services long term versus just a short term fix kind of thing. And yeah, that's the main reason as to why I jumped into it. And a day-to-day operation for us is we have our mental health professionals that are with us. We kind of screen our calls for service to determine, which ones we would prove to be most beneficial on. When we arrive on scene, we make sure that the scene is safe before we bring our mental health professionals up. And then we kind of just start asking questions, which I've found to be huge when it comes to providing the services, because we don't know what services to provide unless we know what they need. So we'll ask those questions, to kind of navigate down that path, and the mental health professionals will kind of jump in and start, figuring out what resources are best for them, and then we'll go that route.
And does that approach help divert some people that might otherwise have been taken into police custody?
Yes, absolutely. So we determine, as well as, what's going on with them in that moment. And is this something that they need an emergency room right away for, or is this something that we can kind of guide them more towards an intensive outpatient kind of treatment, or even so much as just making a phone call to their doctor at their doctor's office and seeing if, they can't get in a little bit sooner to see their doctor, to try to avoid dropping them off at, an emergency room if it may not necessarily be in an emergency situation that requires that.
If you're just joining us, we are talking about local mental health changes that are coming as a result of new state laws. We're talking to a mental health clinician and the Jacksonville Sheriff's Office, and you are welcome to join the conversation. You can reach us on air at 904-549-2937. You can email firstcoastconnect@wjct.org, or you can reach out on social media. Lieutenant, I want to ask you, in terms of screening calls, as the officer mentioned, there are 911 calls, and we know that there are also 988 calls that are coming through. Those are primarily for people who are contemplating suicide or having a mental health crisis of that nature. How do you determine when you're going to send the crisis unit and when you're going to send just an officer on duty?
Well, that's something that the officers in the field they kind of look at their screens, they listen to the calls that are going out, and they kind of decide, hey, this sounds like something where we could be of great assistance. Or the dispatchers, a call could come right from 988, and the dispatchers can directly connect with the officers and the clinicians right there. So it's kind of a two-pronged attack, so to speak. It gives the officers a little latitude. Like, they've got a whole district, a whole area to look at. So they have to monitor that. And not every call that comes into 911 might seem like a call that involves mental illness until, officers get there and start asking some questions. Then our team can respond with those officers. Or conversely, a call might come right away from 911 or 988. Somebody's in crisis, somebody's in distress, there's a history of it. Our officers can respond right away to that also.
So it's not necessarily a dispatcher that's making that decision. It more is the unit monitoring these calls.
It can be, yes.
Yeah. Okay. Um, Dr. Cauffield, the work that you do in the community is, related obviously to what JSO does. In fact, I believe some of their funding comes from LSF
Correct.
for this
Yes.
particular. So what are the expectations that the mental health community has of the officers that are now doing this kind of intervention, and how do you believe they're performing?
Well, I can tell you that their results are extraordinary. The diversion rate for the individuals that they respond to is around 92%. So 92% of people that call expecting or thinking that they might end up in a CSU or jail are diverted to other services. That is a tremendous savings to the community, as well as obviously the right thing to do for the client. So we couldn't be prouder of this program. Our clinicians are so grateful to be able to work with the officers, have them there for safety as well as conversation, able to really triage a situation with their lens as well as the clinical lens.
And is this unit 24/7 available now, Officer Rousselle? I know that there was a time when, you know, it didn't it wasn't available on weekends. There were some incidents that happened over weekends where the unit was not working. What is the cycle now of when they're available to respond to calls?
So right now we're available Monday through Friday from 0700 in the morning to 1500 in the afternoon, 3 p.m. And when we're not available, officers will still, handle the call as they need to, but they'll write reports, and those reports get routed to us. So whenever we come back into work, we do follow-ups on those reports. So the individual may have been, placed into a CSU on a weekend,
And that's a
the
crisis
crisis stabilization unit.
Is that the same as a Baker Act receiving unit?
Yes, ma'am, an involuntary commitment. So they may have already been placed over the weekend. So when we come back in the following week, we will do a follow up with that individual just to continue try to provide those services. And in that aspect, we try to do it, preventative to prevent it from happening again.
Lieutenant Lestrange, are there numbers that you are tracking in terms of diversions like the doctor mentioned, or just overall calls that the unit has handled?
Yes, ma'am. Every month we track the number of calls that we handle, the number of follow-ups that the officers do, our diversion rates, and like the doctor was saying, across the board, the numbers are just phenomenal. And they would be even better. We don't work on weekends and nights right now, but there is a need for that, and we're always talking about expansion. But the numbers themselves, if you look at the data, it proves just how worthwhile this program is, and how much help it gives to the citizens and the police officers.
I mean, I would almost think that the need is greater around those times,
Yeah.
weekends, nights, those are times when people may be using
Yes,
substances
ma'am.
or encountering crises with a loved one that they wouldn't during a regular work week.
Mhm. So part of what our officers in our unit does is educate, our other officers who are working nights and weekends so that they might be able to better handle those situations. And you can't prevent every Baker Act, but you certainly can offer people services, and we can follow up. And like Chris was saying, prevent it from happening again.
What is the expectation of officers now to be trained to some degree in responding to a mental health crisis situation? And is there any resistance to that obligation or this marrying of officer duty to a mental health component?
All I've heard from officers and supervisors and our leadership is that it's a great program. It helps the officers. It helps them understand how to speak with citizens better. It helps them understand the whole process, and it gets them out of a loop where they feel like they always have to take somebody to a CSU. And it's very helpful to them. We're always educating, though. We always have new officers, and it takes a while for a police officer to learn how to kind of use their verbal skills with people who are exhibiting mental illness.
Is there any discussion about having these units accompany patrol officers who I would imagine are encountering people, on the street? I'm thinking particularly of downtown. If there are situations that a patrol officer and a mental health counselor accompanying them would be proactively able to intercept some problems.
Yes, absolutely. Like I said, we welcome growth of the unit. Right now, Chris and his partner, they work downtown, so there's only two of them and one clinician. But certainly, if we had the resources, we could have four officers, two clinicians. Um, it takes those teams working, especially where we have places in the cities where there might be more of a need for them.
What plan is there, if any, for expansion of the program?
Well, we plan hopefully in the next year or two to expand. We've got 12 officers now and two supervisors. Resource willing, if we could have 24 officers with four supervisors, and we've got seven clinicians now. If we could make that 14, I know that's a big ask.
Is that an
But
ask that's being made, like budgetarily?
yes, ma'am.
Okay.
So that's the ask, and I know it asks a lot. We're police officers, so our primary, role is to enforce the law. And this may seem secondary, but if you really look at the program and how it helps, it keeps police officers, um, available for more serious types of calls or calls where they might be needed more.
Got a question from Charles. Good morning, Charles. Go ahead.
Hey, good morning. I got Baker acted about 10 years ago. I was inebriated and, mom had to call. And I was wondering, would that prevent me during the background check of purchasing a firearm, or does the Baker Act show up on their search?
That's a good question. And I don't know the answer. Do you know the answer?
I don't believe it shows up.
I mean, I know that Baker Acts don't show up in a regular court search because they're considered confidential health
Right.
information.
Mhm.
So, but I'm not sure what anybody can access when they're doing a red flag check or something like that.
I don't believe it does. I believe that the background checks are strictly criminal information.
Okay. Um, there are other changes, Dr. Cauffield, that came with this, not just in terms of how law enforcement is interacting on the Baker Act, but requirements that there's data collected. And I thought that the reason for that was really interesting in terms of right now, prior to this law taking effect, there was no requirement for an agency in taking a patient to determine or to keep track of whether that person had Alzheimer's, whether that person had a like a traumatic brain injury, whether they had autism or something that would have been a reason that it didn't qualify as a Baker Act. And so there was really no way of knowing whether the people being brought in were being brought in for a legitimate mental health crisis.
Right. And so that was very problematic, especially, just think about a senior with dementia. They're presenting with psychiatric symptoms that can be confused, if you will, but there was really no deterrent or law that states that you cannot Baker Act an individual with dementia, with developmental delays. And so this law does indeed address that. And so we're very, very pleased with that. Another thing this law is very, importantly addressing is the discharge planning process. So um, prior to this law being passed, there was not a lot of wraparound with the client when they were discharged. There wasn't a lot of collaboration with a family member or a guardian regarding what needs to happen when this person is discharged in the community. And so this law now states a real emphasis on discharge planning, that the client and their family member or guardian must partake in discharge planning, and the guardian agrees, if they are able, to support this client in their journey when they're discharged. Also, things like uh, social determinants of health are factored into discharge planning. Does this person have transportation issues? Do they uh, potentially run the risk of being homeless? What are we going to do about the housing situation? So, care coordination is heavily involved in discharge planning and following that client after they're discharged to make sure they're stable, they're taking their medications, whatever the discharge plan is calling for.
I'm sure that that's a big relief to families. I know that at least anecdotally, we would hear about people whose loved one was discharged. They received no notification, and they would find this person days or weeks later at a homeless shelter, but with not receiving any care, and the family really unable to help.
Yes, yes. And so, very, very happy that this law was passed, number one, and that this is a huge component of the language.
Officer Rousselle, in terms of people cycling through, I know that there's people that officers run into frequently that are people they've seen before for one reason or another. You know the faces, you know those people. This law allows some ability to look at that history as a consideration as well, or a history of substance abuse, in addition to just trying to make a snap decision or using only the information available at that moment. Is that something that is helping to helping officers weed through what could or could not be the best outcome?
Yes, absolutely. So there's a lot of folks that we see relatively often, and it's we try to say it's just a matter of time. Eventually, we may be able to get them to say yes to those services and be able to get the assistance that they need. So it's just a matter of time of just building that rapport, building that trust, and continuously offering those services to help them out.
It must be frustrating, though, to encounter someone weeks later after a Baker Act in the same crisis that you initially found them in.
It can be sometimes, but at the same time, we know that it's a process. It's a marathon, not a sprint, and these sort of things take time.
All right, we've got a call from Danielle in Orange Park. Good morning, Danielle. Go ahead.
Hey, good. I had a situation last year with my daughter. She was Baker active while at work, and over a text message that was sent from an ex-boyfriend. And so I don't believe it was necessary in that state, but I'm just wondering what's the general criteria and how much decision-making power does an officer have to make that decision for someone?
Good question. So, I mean, let's discuss the criteria. We've talked about the fact that officers under this law change will have more discretion, but what is the criteria that go into either a Marchman Act or a Baker Act detention?
Yes. Well, the criteria is, does the person pose a risk of harming themselves or someone else? That's also been expanded to include neglect. So if an officer is responding to a call and they find an individual that is neglecting their personal hygiene, their food insecurity, whatever they're finding that appears to be the person's not able to properly care for themselves, that's another expanded criteria now. Again, it's so critical to have this co-responder team that has not only very skilled officers, but licensed clinicians that can do an assessment and determine is this truly a situation where a person does plan on harming themselves or someone else, or is it something else, impulsive situation that can be de-escalated and diverted to a less restrictive environment.
And it's interesting, harm to self or others has always been that understanding of the Baker Act. But this new definition, as you say, expands that somewhat. So if someone's in danger of becoming ill because they don't
Yes,
have food, clothing, medical care, housing, that can also be a trigger now. Or if somebody's in danger of dying for those reasons.
absolutely.
Yeah. Um, and so this comes at a time, Lieutenant Lestrange, where there's increasing attention on law enforcement dealing with mental health calls, some very tragic incidents that have happened nationally, some locally, I think, that involved someone who was a suspect with a mental health issue. Is there is that what is driving this conversation for law enforcement trying to respond to that problem, that perception that perhaps there hasn't been enough attention paid? Or is it more about conserving resources and finding alternate ways to process suspects?
Well, I think on the front lines, if an officer encounters somebody on the street or through a call, and the person may be suffering from a mental illness, if that person, let's say, has a weapon, has a firearm, has a knife, a machete, an officer has to take the best course of action at that time. And those are extreme situations, but they do happen. In those situations, an officer has to think about, is this person endangering other people? Are there some types of crimes being committed? Or, is it somebody just holding a knife? Either way, it's a dangerous situation. And I think officers learning how to speak with citizens who may be exhibiting signs of mental illness, educating officers, getting them more training in these areas certainly would prevent incidents in the future. But I would, I have to give credit to officers who might be facing a potentially seriously dangerous situation and have to allow them the discretion to act as they need to act.
How do you feel, Officer Rousselle, about how this unit and working in this unit has perhaps changed or broadened your perspective of the work of law enforcement?
Oh, I mean, it's definitely changed my perspective on, not just law enforcement, but life itself. People struggle with mental illness every day, and there's no shame in having a mental illness. I tell people it only takes one bad incident to, cause you to experience some sort of issue or some sort of, mental health. So I mean, having worked in this program, I understand now that it's perfectly okay to not be okay, and that there are services and there is help that you can get for your situation. So
I've seen figures, Dr. Cauffield, that as many as, half of kids, adolescents, and children will have some sort of mental health crisis or diagnosis. So what the officer's saying really does seem to hold, that the number of people that could be in a situation where they'd require an intervention or a decision about whether an intervention is appropriate would be made.
Yes, absolutely. We are frankly living in a national mental health crisis. The pandemic wreaked havoc on everyone. I don't think there's one person that went unscathed, particularly those that were living with a mental health challenge. It truly exacerbated it, and so although the numbers seem to be coming down for our young people with thoughts of suicide, um, somewhat, there's still a real crisis that we're dealing with post pandemic. And so the more that we can help people connect to community resources, and if they require medication, get the medication they need, stay on that medication, um, get a therapist, whatever the treatment is for their road to recovery, uh, the better off everyone is going to be. The client themselves, the family members. This is a community issue.
Yeah. Well, thank you for the work that you do. Thanks for talking to us about it today. Dr. Christina Cauffield, Jacksonville Sheriff's Officer Chris Rousselle, and Lieutenant Robert Lestrange Jr., thanks so much for being here.
Thank you.